I'm Dr. Ken Anderson here at Myeloma 2015 in Boston, Massachusetts. And every year we talk about this, but there's amazing progress to be made over the last 10 to 15 years. Multiple therapies have translated from the bench to the bedside and really prolonged patient survival 2 to 3-fold. But the best is yet to come, and the excitement at this meeting is literally palpable. We're going to talk about 3 different subjects that were highlighted at this meeting. A little bit about the myeloma progenitor cell and what we've learned about its biology and how to identify it. The importance of genomics in terms of understanding the disease and categorizing patients, understanding perhaps new targets or new pathways to target. And then finally, a little bit about using genomics in clinical practice. What are the implications for how you take care of patients with multiple myeloma? So with that as an introduction, I'm honored to be joined here by Dr. Leif Bergsagel from the Mayo Clinic in Scottsdale, Arizona, and by Dr. Gareth Morgan, originally from the United Kingdom. We're now in New England, I want you to know, but he's now from the University of Arkansas, where he directs a wonderful myeloma center there. So welcome.
Thank you.
So the first thing we've been going to summarize is the session that was held about myeloma progenitor cells. And over the years, this has been a controversial topic. The controversy isn't whether the cells exist. The controversy is what are their characteristics and what can we learn about them that can inform us in terms of not only biology but treatment. So Gareth, maybe start with you. Are there any lessons that came from this session?
What I think informs this discussion is around the intraclonal heterogeneity that's present in myeloma. If there's intraclonal heterogeneity, it must mean that each of the clones comes from a different unit of selection or tumour initiating cell. So almost by definition, those cells must exist theoretically. It's just very, very difficult to describe what they are and to touch them. We've done some experiments in mouse models where you can transfer different clones to different mice from the same patient at different times. So those are all kind of formed by an individual tumour initiating cell. So I believe in the concept. I find it very difficult to interpret the data that we have now. These cells are probably 138 negative, but that's about as much as I can divine, and they're in some sort of equilibrium with the 138 positive population, and that's about as far as the data goes, I think.
Okay. And Leif, you have any thoughts?
I think I learned something today, and this is from the talk from Roger Tiedemann, who has talked before about how some of the therapies that we use now with proteasome inhibitors really target cells that secrete a lot of protein, and so in response the tumor begins to secrete less and is less of a plasma cell phenotype. And what I learned today was that he was able to frequently take what he described as non-plasma cells from the bone marrow of patients and to culture them with plasmacytoid dendritic cells and induce them to proliferate in vitro quite frequently, which actually we have a hard time doing with tumor cells from patients. And so I think there's promise in that technology to understand the cell biology of primary patient samples that we don't have today. And understanding the clinical significance, I think, is going to take longer. But yeah. I think that it was very well supported by data that he had looking at genetics and other things. That I think that there's some useful information there.
Yeah, I just would completely agree with both of you. And when I think about it, the concept of a progenitor cell clearly has to exist. It's probably a good cell to target. And so there's no argument there. I think that Roger's talk, Dr. Tiedemann in particular, pointed that out, which is the importance of the microenvironment. So what he was able to show is that you could expand these cells, as you mentioned, Leif, on a bed of plasmacytoid dendritic cells, which are cells that are in patients with myeloma bone marrow that promote tumor and also, unfortunately, don't function to stimulate immunity as they should. And there are other cells like myeloid-derived suppressor cells that are the same kind of issue. But what I think is exciting is that there's more elegant information about what the progenitor cell may be. some studies of the microenvironment, ultimately this is really a functional definition, right?
Absolutely.
It's a cell that we think can reproduce generation to generation in a skid mouse or some other model, myeloma. And I came away that there's still controversy about where, you know, I guess it's CD138 negative, but what are the other markers it expresses, et cetera. The way that I hope will get sorted out is with some of these model systems where they can be expanded and functionally evaluated, et cetera.
Yeah, it's certainly true that the talk by Bruno Paiva seemed to be not in agreement with the observations from Dr. Roger Tiedemann. And I guess what Dr. Paiva talked about was cells he was studying in the peripheral blood. And so maybe that some of the differences that we're seeing relate to technical aspects of the studies, but certainly there doesn't seem to be a clear consensus about the stem cells.
So Bruno Paiva's talk about circulating tumour cells as well, the fact that you're able to quantitate cells that are circulating that belong to the myeloma clone is, I think, very interesting in seeing myeloma almost as a metastatic disease. And the ability that Suzanne Trudel presented to look at these circulating myeloma cells at very low levels and do a blood biopsy rather than a bone marrow biopsy, I thought she did a really great job in that talk.
I couldn't agree more. And you know, we do need to make sure that the cells in the blood or the sequencing of DNA in the blood is associated with tumor burden in the marrow or systemically. But very exciting leads, again, reflecting the advances in genomics coming to the bedside.
Perhaps the interesting thing from Suzanne Trudel was that some of the genetic defects she was finding in the DNA that was circulating in the blood was much less frequent in the bone marrow. So there was enrichment for these cells with these abnormalities to circulate.
Yes.
RAS mutation, I think that was.
Yes. I think it's fascinating. Again, I think we need to be open to the fact that the cells circulating in the blood may be different in their biology.
No,
There's
absolutely.
a reason that they're circulating instead of still in the bone marrow. So, but it could not be more exciting time to be able to test these ideas now.
So Jonathan was talking as well about epithelial mesenchymal transition in the context of myeloma. I mean, it's a solid tumour context,
Right.
but a couple of people, Irene as well, has mentioned it. It's really quite a compelling idea that a kind of circulating tumour cell may give you insight into that sort of process. And if you can understand the genetics of that, then I think that might be quite powerful.
Very powerful indeed. So there was a section that, a session actually devoted totally to genomics. Jonathan Keats, among others, presented the update of the COMPASS trial so far. And I think the excitement there, from his talk and also from Mark Rab's talk, who's one of the leading myeloma doctors in Germany, is that we're finding more and more abnormalities, mutations, clones, subclones, quite a very heterogeneous spectrum to start with, and it gets more complicated with time. But what it's all pointing to, and I would love you to talk about it, I think you in particular, Gareth, have focused on this, but no matter how, by mutation, copy number, cytokine, adhesion, whatever, plasmacytoid dendritic cell influence, there seem to be pathways that are really implicated in myeloma, or molecules like MYC. But there are there's common biology here that we can now start to think about and target. Wouldn't you say?
So I think the compelling thing to me is the data's not all come from one group, and it's all totally internally consistent. We know the spectrum of mutations in myeloma. It's a disease of MYC, RAS, and deletion of negative regulators of the NF-kappa B pathway. And the challenge now is to get that sort of information available for all the people you see in the clinic. So there was a lot of talk about how to do that with myeloma-specific panels, and we're just now in a position where you can enumerate all of the relevant mutations, copy number change, structural change, build that into a panel, and pretty soon we'll be able to have that for all patients with myeloma, and then we'll be able to see, can this be used to improve clinical outcomes?
Yeah, I couldn't agree with you more, and I think that I actually, Leif, you gave I think probably the best talk today, but the issue is...
Well, of course.
Did you give a talk today? No, Gareth wasn't speaking, so it'll be better. But in any event, no, Leif, you did tell us, here's the different ways we have, we looked at if you want, the profile, right? And we've looked with FISH and we've looked with profiling, but you really came, and I thought in a very rational, cogent argument to what, can we actually replace some of the tests that we've used before? What are the common minimal things that we really want to know, and what are the best tests to detect them? So do you want to just summarize that?
Sure. Currently, for instance, we use, or we have been doing conventional metaphase cytogenetics at the Mayo Clinic. And I think we've decided as a group that we would like to replace that, so that when we bring new tests in, we're not just adding another test to everything we're doing, we're really trying to move the field forward and drop one and add another one. But the information that we want to know is the immunoglobulin gene translocation, because that's really important, the MYC translocation, and then the mutational status of the number of genes that are commonly mutated, as well as some of the genes that are copy number changes that we think are prognostically important, like 17p deletion or 1q. And there's many different competing technologies. I think all of them will work, but you can probably confine yourself to perhaps one DNA-based technology and one RNA-based technology. And the DNA-based technology could be based on what Gareth Morgan, sitting right here beside me, showed you could do with a custom capture array and also identify not only structural variations but mutations. And then the RNA could be done by microarray, or probably better today done with RNA-seq.
Right. And I think one of the other messages that came out loud and clear is that given the heterogeneity right from the outside, the multiple clones, that such analyses that you're talking about are going to need to be done over time, because there's an evolution with time. And I think one of the messages that came out, maybe Mark Grab's talk, where he actually did immunoperoxidase staining, primarily focusing on the RAS-RAF-MAP kinase pathway. But the idea is that we're likely going to be facing combination therapies here. We can identify a pathway, but it may not be enough to just block at one level of one pathway for fear of alternative pathways or feedback, so you could actually paradoxically activate the same pathway you're trying to block. So it's going to probably be combinations as well.
There's been a kind of series of literature recently kind of describing the fact that if you do one thing, there's always a consequence, and so you have to be very careful about introducing these things directly into the clinic. But it does look as if the RAS pathway can be targeted. The experience targeting BRAF, I think, says that even chemotherapy-resistant tumours will go into a remission. It's keeping them in a remission and working out how to do it effectively all of the time.
The other thing it really supports is the idea of immunotherapy as a way of dealing with all this clonal heterogeneity. And in fact, an observation that Dr. Morgan made about the fact that the MAFs, patients who got MAF translocations, have much higher levels of somatic mutations, I think is really important, because we know, or that there's published data, that the mutational load correlates with response to checkpoint blockade. And so they would be high-risk patients who don't benefit really from anything we're doing now, maybe just the ones where we want to use that therapy.
Yeah, I'd like to see the data in the COMPASS study, where they've got whole genome coverage rather than just whole exome.
It's the same.
But
Yeah,
that
no.
must have a huge mutational load.
Yeah, I could not agree more. I think that the immune treatments, or just the concept of immune therapy in myeloma, is really quite exciting. It's not a new idea. Some of us have been looking for several decades, but I do think the idea that this it's mutational load, but it's all the other multiple clones and deletions that come, et cetera. So the genetics makes these patients extremely high risk, or they evolve to that situation. And the theoretical possibility, anyway, that with an antibody, an immunomodulatory drug, or maybe the two of them with a checkpoint inhibitor, combination of immune approaches, I think, offer great promise to deal with the cell, I won't say in spite of, but maybe even a cell that has some of these very high-risk P53, et cetera, abnormalities that really we don't deal with very well with targeted therapies. I think the other thing, just to mention quickly, is, the melanoma, which is often confused with myeloma. Myeloma is obviously much more important, but we have lessons from there. I mean, they have done the pathway that we are talking about here right now, the RAS-RAF-MAP kinase pathway. They've done blockade with the BRAF inhibitor, along with other inhibitors, MEK inhibitors at the same time. That's probably a message for us. And I also think they've combined now some of the targeted therapies like this pathway with checkpoint inhibitors, right? So I think that could be our future. And so very exciting how we're going to apply genomics and now in this case integrate it with immune therapies into the clinic. So
it's a real challenge.
it is. So I think hopefully we have gotten you excited about the future. We really are honestly expecting major breakthroughs in myeloma. Many of our patients have chronic illness already, but what really these sessions that we've focused on here have helped us to understand is what might be the initiating cells, what are the cells that we really need to target in myeloma, and what is their genetic profile, and what are the approaches, whether it be targeted therapies, combinations, or maybe even immune approaches that may allow us to be very effective in that setting. So honestly, the future is even more exciting than the past, and chronic illness with curative potential is a realistic goal.